friends, today we have a special guest with us, Dr. Denny Patel. Dr. Denny Patel graduated from Loma Linda University with a Master in Physical Therapy. He has also passed the Certified Strength and Conditioning Specialist examination. After practicing for 10 years, he went back to school and finished a doctorate in physical therapy. He has been practicing physiotherapy for over 21 years and has been teaching for over 16 years. He is a certified clinical instructor by the American Physiotherapy Association and took students and interns on regular basis. Dr. Denny Patel currently teaches human anatomy and medical terminology at Coastline, human anatomy and motor control at Cal State University, human anatomy at Santa Ana College, and pathology at Cambridge University. Thank you.
Hi, Dr. Denny. So can you switch on your mic? So your mic is off.
Can you hear me now?
Yeah.
Perfect.
Yeah.
All
Perfect.
right. All right. We are ready to go, huh?
Yeah, just a minute, sir. Welcome, everyone, and I appreciate your enthusiasm. Before starting the program, there were so many friends who were already live and who were waiting and messaging on the YouTube channel. Thank you so much for that. We really appreciate that. And we wish Spinex Global is wishing you all a very good learning process in this level 2. So stage is yours.
Okay, perfect. All right. Welcome back, everybody. I hope you got the week to practice taking some measurements of the infrasternal angle. Today, we'll go over the treatment aspect of it. It's one thing to measure it, but then what do you do with that? So I'll show you a video of how I measure it. I had to use my son as a patient. So I did want to give special thanks to Dr. Neeraj Bansali to really organize this. A couple of the other people that I've taken some of this treatments from is Bill Hartman from IFAS, Zach Couples. He's really good, and the PRI, of course. So if you want to find out more information, you can definitely look up Bill Hartman and Zach Couples. But again, the purpose of this is to make it a little bit easier to understand, because if you haven't taken the courses, sometimes the terminology can be a little confusing. So I just wanted to make it as simple as possible and for you to implement it right away. So just before we start, I wanted to show you how I measure it. And so again, the patient is going to be supine. I usually mark the xiphoid process. We're going to look at the angle of the ribs 8 through 10, and then we're going to measure just the static angle first, see where they're starting from. Okay, so there's the angle of the ribs, 8, 9, and 10 right there. There's the xiphoid process. And then I would take the goniometer, and then there we go. So if you can see, I line that up right there. And first we take a static measurement first. So, and for him, I got about 80 degrees. Okay, let me show you that again. This is the key, because if you don't know how to do this correctly, then there's no point in going on for the treatment there. Okay, so xiphoid process, ribs 8, 9, and 10, and ask the patient if you can mark on them. You don't necessarily have to, but it just makes for a more accurate measurement. And so if he's starting at 80, 85, 90 degrees, that's a good start. Remember, now we're not concerned about the static portion of it. We want to see how he moves when he's taking a deep breath in and then exhaling. We want to see if this rib angle is going to move. On inhalation, is it going to go wide? And on exhalation, is it going to go narrow? On patients that have compensatory patterns, it won't move. Those are the patients that we can help. If it moves, and let me show you the next. So if you see that, I put the arms overhead about 90 degrees here. And if it goes too far, you see how this back is arching, then I bring the arms back. You don't want the back to arch too much. So play around with it until it's perfect. Find that angle again. Okay, so again, it should be at 80, 85 where you started. And then you ask the patient to take a deep breath in. You see how as he took a deep breath in, it got wider. So his went up to 100, 105. And then as he exhaled, it got narrow to about 65, 70. That's perfect. That's perfectly normal. So on the inhalation and the exhalation, we should see it, on the inhalation, we should see it go wide. And then on the exhalation, we should see it go narrow. That's what we want. That's perfect. Okay, so patients that are stuck in wide are usually going to be your patients that are overweight, usually males, and basically they're stuck in that inhalation pattern. Not always, but you never want to put everyone in the same category. But usually what I see is people that are usually heavy, overweight, are usually stuck in that wide. And those are the people that we have to teach them to exhale out. And I'll show you the exercises for that. And then those that are really tiny frame, usually females, lean, those are the ones that are stuck in narrow, and I'll show you what compensatory patterns they usually present with. So let me show you this again, just so you understand this. So again, I have the angle right here. Okay, that's what we measured first. I'm taking the arms back, and as soon as his back starts to arch, I stop. Okay. So, and then I'm going to put the goniometer. Now, if you don't have one of these, you can measure it with your arms. That's okay. You're just looking for that to see if it's going to go wide or narrow. So as he takes a deep breath in, you see how the angle increases? That's normal. We want that. That's perfect. And then as he exhales, it goes into narrow. So the transition from wide to narrow is what we want to see on patients. Okay. Now, patients that come in, when you ask them to take a deep breath in, if they're already stuck wide, they won't be able to expand anymore, or they'll just be stuck. And when they go into narrow, they won't be able to go wide. So that's the key. If they're able to go from wide to narrow, then it's perfect. Okay, so that's the key. Now, I did want to show you. I don't know. So what I was going to show you here is, I'm going to take this volume down a little bit, and then I'm going to narrate this. So I have this umbrella, which should represent the diaphragm. I have, this is the infrasternal angle that I'm kind of demonstrating. So as you inhale and exhale, that's what your diaphragm does. So this is the angle that we're measuring. So when you inhale, you see how the diaphragm descends, goes down, and that's how your infrasternal angle gets wider. See, I thought it was a good analogy for you to see. As you take a deep breath out, you see how your infrasternal angle gets narrow. So inhalation, exhalation, inhalation, exhalation. So this is a good visual for you to understand inhalation, exhalation. Now, imagine if somebody is down here, they're stuck. So their diaphragm is stuck right here. They can't inhale or exhale. Then you can see the problems that are associated. Or you have a patient that's stuck narrow and they can't inhale. So you see visually now how that can be a problem from patient care if they're not able to expand their diaphragm back and forth, if they're just stuck in one position. So hopefully that helped. I find that visual really, I think it plays a good role in trying to see it. Sometimes we can't see the diaphragm. You're like, what is this guy talking about? All this diaphragm and infrasternal angle. But then when you look at the umbrella, and you're thinking, okay, as I open the umbrella, that's the diaphragm going down, inhalation. As I close the umbrella, that's exhalation, and that's how the infrasternal angle changes. So hopefully that was beneficial. So why do patients have a wide infrasternal angle? So a wide infrasternal angle, usually greater than 90 degrees. Sometimes it can be as wide as 110 to 120 degrees. They usually present with an increase in a thoracic kyphosis. They have an increase in lumbar lordosis. These are your patients that are usually overweight. They have a nutation in the sacrum, tilting of the sacrum forward. So a wide infrasternal angle would mean that the false ribs are in an inhalation position, causing the diaphragm to be overly flat. So you saw from the umbrella, overly flat. Now here's the key. Similarly, the infrapelvic angle remains wide, and the pelvic floor is flat and does not create room for the abdominal gut contents to descend. So any of you physios that do women's health, or if you do pelvic floor therapy, you would want to check the infrasternal angle, because guess what? It will affect the pelvic floor as well. And so if you're struggling to help your patients with pelvic floor and you're thinking, how come I'm not getting the results? You may want to check the infrasternal angle, and it will open your treatment pattern, and you'll see better results. So the infrasternal angle and the infrapubic angle are greatly associated. So pelvic floor therapy, women's health associated with infrasternal angle, you're going to get amazing results with this if you can do it correctly. So observable phenomenon would be the guts expanding outwards during inhalation, big stomach, big kyphosis, creating that imbalance. Now, patients are usually obese, men, deconditioned, but not always. That's not always the case. So now that we understand a wide infrasternal angle, what are we going to do about it, right? So we studied the philosophy last week, but what do we do about this? Okay. So again, how do we treat it? Wide is greater than 100 degrees. This demonstrates an inspiratory position of the diaphragm with increased accessory musculature actively pulling the rib cage upward. Okay, so it's pulling the rib cage up. This position is likely driven by accessory muscles along the thorax. So what we want to do is any kind of treatment for the wide infrasternal angle, we want them to be reaching overhead. And the reason that you want to be reaching overhead is that it places the abdominal muscles and the viscera on stretch. And the key muscle, and this is very important to understand, the key muscle that we're going to use to drive this wide infrasternal angle inside is the external obliques. Okay? The external obliques is what's going to help us drive this infrasternal angle in. Okay? So arm elevation increases the diaphragm's demands during inspiration and potentially shifts the thoracic accessory breathing muscles towards a posturally oriented roll. This position increases the intra-abdominal pressure, and what it will do on that forceful exhalation, you'll be able to recruit the external obliques and then cause that. So I'm going to show you my top 3 exercises of how to treat someone that has a wide infrasternal angle. Okay, so let's play this. All right, so this is again a wide infrasternal angle. Their diaphragm is descended, so we want them to be able to recruit the external obliques. Okay, and so the reason that this is important is that their obliques, external obliques, are pretty much shut off here. So I usually, now you don't have to use a ball. You can put their feet on a step stool, but just so it's 90 degrees, okay, you're getting the hamstrings to fire. You're going to do a little bit of a tilt, not to the point where they're lifting their bottom off the table, but the key here is the arms need to be overhead, not so overhead that they get an arch their back has to stay flat. So that's the pelvic tilt right here. But here, then you cue them. It's a forceful exhalation. So you're going to say, take a deep breath in, and then as I do a forceful exhalation, see how my feet are digging into the ball to get the hamstrings to fire. I've got the pelvic tilt, okay? And I'm breathing a forceful exhalation. This is my number one exercise for someone that has a wide infrasternal angle. And again, the reason that we want to do it this way is the arms overhead is I want to recruit the external obliques. And the external obliques will fire to bring that wide infrasternal angle back down to normal. The hamstrings will help fire and they'll tilt the pelvis. Hamstrings are key here. So let me show you the video again. So digging the heels into the ball. Okay. Hamstrings on. My back is flat. Okay. And the key is take a deep breath in, but it's a forceful exhalation. So it's going to be take a deep breath in and then you can put your hands on their rib cage if you want and help them guide that from a wide to narrow if you like, or you can just teach them how to. So I do about 3 repetitions of this, and then I'll measure the angle again. If they're having difficulty, we can do another round, but usually after about 3 to 5 repetitions, they're able to move a little bit better. But you know, some patients that have been stuck in this angle for many years, it might take a while for them. So you're going to have to give some tactile cues and some verbal cues to do that. So again, number one exercise, this is the first exercise I start with, the wide infrasternal angle. You may use the ball. If they don't have the ball, they can just put their feet on their sofa. But the key is digging their heels so their hamstrings fire. Okay, so that's the first one. Now, my second exercise that I like to use is so this one is more of a quadruped position. Now, if your patient is unable to get into this position, they may not be ready for it. But see, I'm quadruped, but look at my arm placement. The arm placement has to be above, just like we're reaching overhead. So imagine me supine. So this way I'm overhead. I'm doing a little bit of a tilt right there. Okay, so I'm going to take a deep breath in. Take a deep breath in, and then see how I exhale, getting my external obliques to recruit there. Okay, let me show you that again. Let's go over this again. All right. So if you look at this right here, 90-90 position right here, back straight. My arms are overhead, just like this. You don't want the arms underneath here. That's different. That's a different exercise. So the key is the arms have to be overhead like this, almost where their ears and eyes are. And that way you'll get a stretch on the abdominal viscera, and you'll get a better recruitment of the external obliques. This is the key. Okay. And then you have them take a deep breath in, and then the forceful exhalation. Remember, anybody that has a wide infrasternal angle, they have to be able to do a forceful exhalation. More exhalation than inhalation. So really, if they inhale for a count of 4, I want you to teach them to exhale for a count of 8. Okay, double their inhalation. So if they can only inhale for 2, then they exhale for 4 seconds. Okay, this is my second exercise that I do. And you can do all these in one treatment session. So start with the one supine, then go to this one. Let's say you can't get the patient in this position. So I give you an alternative is standing. And this is a good one too. And so you have this little ball right here, and you're going to put that between your knees. Okay, so you get those adductors to fire. And basically, they can hold on to a table or the sink. But the key is, okay, so I've got that little ball there just to kind of keep them stable. And again, look at my arm placement. It's almost just like I'm reaching overhead here. Okay, and so I do a little bit of a tilt, back straight, squeeze the ball, get the adductors to fire. But the key is also, I want to do a forceful exhalation. So look at my forceful exhalation, and then I'm going down again, getting those external obliques to fire. But the key with a wide infrared is the arms need to be overhead. So if they have a sink to hold on to, then that really works. So let me go right here, pause it. This is what you're looking for. See, back straight, squeezing the ball, getting the adductors, legs straight. Okay, but the key is reaching overhead like this. This is my third exercise that I like. Now remember, if they can't go quadruped, they can't go on their knees, then you can definitely do these. These are probably the top 3 exercises to fix a wide infrasternal angle. And they're excellent, and you'll see some good results with that. Okay, so very simple. Like I said, none of these are complicated, but you just have to understand the reason why we're doing this. So anybody with a wide infrasternal angle, our goal is to get the external obliques to fire. And if the external obliques will fire with a forceful exhalation and arms overhead, then you can get creative with your exercises. Once you understand the philosophy behind it, you can think of anything, any kind of exercise. So let me show you. This one is a little bit higher level for your younger patients, but this is a great way to recruit external obliques. So I have them overhead. So it's a reverse lunge. Okay, so it's a reverse lunge. And so again, this is going to be a little bit higher level, but I step back and then I rotate and I'll get the external obliques to fire as I step back, and then I go the other way, right? So you get both. Okay, and remember, so let's go back here, right here. So as I'm stepping down, and then he goes right here, right there. When I turn is when I do my exhalation. Okay, so let's watch that again. So I'll tell you where the inhalation comes in and where the exhalation. So I inhale right here and I exhale right there. Okay, so I'm inhaling right here and then exhale, and do 3 to 5 repetitions. And those are my top exercises for a wide infrasternal angle. See, I told you I'd make it easy for you. The key is, you're like, oh, that's real simple. That's right. These are simple. The goal is it's not to be complicated. You don't need any fancy equipment. You don't need anything. You really just need to understand the philosophy, and then you'll be able to really implement that. Okay. Now here's another higher level one. So this one's for my patients that are a little bit more advanced. You can use a kettlebell or weight, but this one, I'm half kneeling. So I've got the pelvic tilt right there, and I've got the weight. That's 20, 25 pounds, but you might just start with 5 pounds. But see how when I go overhead like that, I really have to stabilize with my external obliques. So I'm exhaling, see, as I go around, stable, and then coming back here. Okay, so take a deep breath in, and then I exhale, and there we go. This is a really good exercise right here. Okay, so you have to be really stable. And let's say they're not able to, whoops, let's see. Oops. Let's pause it right here. Okay, so again, half kneeling. You can put like a pillow right here so they have something to, if their knees bother them. Okay, the key is I'm straight, a little bit of a tilt, and then I'm taking a weight. Again, If they can't do a weight, then just give them, just have them do the motion. You want a little bit of a weight just so they can help recruit their external obliques. Okay, this is higher level. I wouldn't start, this is maybe after a couple sessions that you might want to do this, but my top exercises are the first 3 that I showed you. So it would be the one with the ball, the one that we're quadruped, and the standing one. Okay, so those are my top exercises for that. There's some higher level wide infrasternal angles. There's the Zerker squats, goblet squats, front rack squats, landmines, neutral grip dumbbell press, and then add a band around knees with squatting. You can look these up on YouTube, what these mean, but these hardly is the case where you'll get to the point where you'll do these. The top 5 that I gave you, those are the ones that I really want you to focus on. Okay, so that's for wide infrasternal angle. Now, what about our patients that have a narrow infrasternal angle? Okay. The narrow infrasternal angle is usually less than 90 degrees. They have a decrease in thoracic kyphosis. They have a really flat back. They have a decrease in lumbar lordosis. They have a counter nutation in the sacrum. Having a narrow infrasternal angle would typically mean that an individual can achieve expansion at the front of the thorax, but not expand the posterior part of the thorax. So they really have trouble getting air in the posterior part of their thorax. That's why you have the flat back. Scapula may be biased towards adduction, closer to the midline of the spine. Poor shoulder range of motion. Okay, that you'll see. When an infrasternal angle is too narrow, less than 90 degrees, the diaphragm can be put into a difficult position where it can no longer move through regular ranges during breathing. So the external obliques can also end up overactive and pull the ribs too close together. So in order for us to get the patient out of the narrow infrasternal angle, we're going to recruit 3 different muscles: pectoralis major, serratus anterior, and a little bit of the internal obliques. Now, going back to the pelvic floor again, a narrow infrapubic angle would also mean that the pelvic floor is overly lengthened, which doesn't create enough abdominal pressure. So just like the wide, the narrow infrasternal angle will affect women's health as well. So pelvic floor, even for men, if they have some pelvic floor issues, the infrasternal angle will affect it. So anybody that has a women's health clinic that does pelvic floor therapy, start checking their infrasternal angles and see what you find. So usually narrow, usually mostly skinny, lean women have a narrow infrasternal and therefore need a check, but not necessarily, but anybody that has a lean physique, flat back. Okay. Now, our goal is to get this, if it's narrow, and our goal is to get to 90 degrees. Narrow infrasternal angles are progressives from the wide, so sometimes they've compensated more. Remember, as the diaphragms descend further, the lower ribs displace inward. So we want to do quadruped. Okay, so again, the arm elevation mentioned above places accessory muscles on greater postural demand. The nagging reach produces scapular protraction. So remember, with a wide, our hands were overhead like this. But with a narrow, they need to be straight down 90 degrees right here. So that's the difference between a narrow and a wide. So wide, we're reaching overhead. Narrow, we're reaching straight here to get the serratus anterior, pectoralis. And see, we're trying to create this posterior expansion. Most people that have a narrow, they won't be able to get air back here. That's why you want them to be quadruped. Because imagine if they were on their back, they'd have a difficult time getting that. So for most patients with a narrow, this exercise works really well. And I'll show you the video of it. Okay. So just to recap, a patient with a wide infrasternal angle, we're trying to recruit external obliques. Someone with a narrow infrasternal angle, we're trying to get serratus pec, and internal obliques to fire to get this. Okay, so again, this is a similar exercise, but now we're going to recruit the narrow infrasternal angle. So we're going to recruit serratus. We're going to recruit pectoralis. And on the exhalation, it's more like you're fogging up the glass. So it's a, okay? So it's not a forceful exhalation like in a wide. It's more of a, like you're cleaning your eyeglasses. Okay, so very similar setup to the wide. My feet are digging in, so getting the hamstrings to fire, doing a nice little pelvic tilt there. Okay, but watch my hand placement. You can put the ball right there between your knees to keep it stable, but watch my hand placement. Here's the key. Wide was overhead, but with a narrow right there. That's the difference between a wide and a narrow, because I want my serratus and pec. So I usually have them give a little pointer, make a little gun right there, and then I'm reaching overhead just like that. You see that? So take a deep breath in, and then it's just a, not a forceful exhalation, but like I'm cleaning my glasses like a, okay? And that will recruit serratus, that will recruit pec, a little bit of internal obliques right there. Let me pause it right here. Okay, right there. So that's the setup right there. You see the difference between a narrow and a wide treatment? The major difference is, you see, my arm placement for the narrow is 90 degrees right here. For my wide, it was overhead to recruit the external obliques, but for the narrow, I'm getting the serratus, pec, internal obliques, and the breathing is important. It's not a forceful exhalation, but it's just a, okay, like fogging up a glass. That's the kind of like the, excuse me, the verbal cues that I'll give a patient. Is like, okay, imagine you're cleaning your eyeglasses and how you fog up that glass. All right. Now, here's my second exercise for a narrow. All right. So if you look, remember with a wide, we were overhead. This time I have them make a little bit of a diamond shape right here. So you watch this, little diamond shape. Now, again, for some patients, these are going to be your skinnier patients. So they're going to be able to get into this position. Now, take a deep breath in. And you know what the serratus does, right? So see how I push down, and as I push down, my knees come off of the table. So that's serratus. I'm getting serratus, pec. Okay. You don't want them to lift their butt up too much. Okay, but the key is getting the serratus. See that you don't want them to do that. Okay, so watch me again. So it's there. Let's go back a little bit, right there. Okay, so if you look, I'm in the quadruped position, back straight. You can be more at a 90-degree angle here. Arms making a diamond shape right here. Ask them to take a deep breath in, and as they exhale, it's just like fogging up glass, and you're recruiting the serratus anterior. All right. So I hope that this makes sense to you, because this is the key difference between the wide and the narrow. And you'll be surprised after you do a couple of these, your patients, their inhalation, exhalation will really start to improve. Okay. So let me just show you that again. So here, and then I'm lifting up here. Okay, so that's recruiting the serratus anterior. All right. Now, here's another good one that I like for a narrow. So I get a band like this, put that around. I'm in a half kneeling position. I've got my back straight. And again, we want to recruit serratus and pec. So watch me here. I take a deep breath in. Now I'm recruiting serratus as I'm punching straight like that. This is really good for a narrow infrasternal angle. So again, half kneeling. I've got a band around like this, and I'm punching straight ahead, okay? And that's going to recruit serratus, and that's going to help my narrow infrasternal angle. So really good exercise. So very simple exercise, but the key difference between a wide and a narrow infrasternal angle is basically we're punching straight ahead here, trying to get serratus, and we're trying to get pec. Okay, so those are the exercises for a narrow. Now, here's some higher level narrow infrasternal angles. You can do sit back squats, box squat, traditional push-ups, squats with ball between the knees, and promote internal. Okay, so the traditional push-ups, the box squat, again, you can look those up, but keep it simple. And these are the key with this. So let's go narrow here. Let me show you. Okay, so narrow, that's the number one exercise right there for a narrow. 90 degrees here, 90 degrees. Recruit hamstrings, pelvic tilt right there. Okay. The other exercise, quadruped. They've got the diamond shape right here. They're using their serratus and pec to lift their knees overhead. I'm sorry, off the table right there. Okay. And this one is a great exercise where they're half kneeling and basically they're pushing straight up just like that. Boom. Okay. So this is a great exercise as well. So those are my top 3 exercises for the narrow infrasternal angle. And you'll see some good results with that. See? Pretty simple, right? Everything, try to make life easy for you. If you don't have a band like this, you can have them get a weight and just push forward. But we all have rubber bands, so definitely you can do that. Okay, what happens if they have an asymmetrical infrasternal angle? Meaning, what if it's wide on one side and if it's narrow on the other side? Because sometimes patients will have asymmetry, and that happens. I've had one patient or several patients just in recently that had an asymmetrical. Well, let me show you what you do. You combine those exercises. So this side, my right side, they have a narrow. So you can see I'm pushing 90 degrees right here. Okay. And if this side is wide, then my hand is overhead. So now you understand the concept. Anytime if they have wide, I'm going to go overhead. If I'm going to have a narrow, I'm pushing 90 degrees. Now think about this, the other exercise. So this one on my right side is still narrow. So I'm going to have this 90 degrees. But if I have a wide on this side, then I reach overhead. Very simple. See, you understand the concept, then you can be very creative with your exercises. Okay, so again, if you look at this, you can see that because my hand is at 90 degrees here, I'm trying to fix a narrow on this side. And because my hand is overhead like this, I'm trying to fix a wide on this side. Now, how often do you get someone with asymmetrical? It depends. It depends on the patient, but you will see asymmetrical. So we want to make sure that we're treating that. Don't assume that they have symmetry on both sides. Okay, so that's a really good exercise as well. All right. Now, what's the take-home message? Again, today's session was, pretty easy, but I wanted to show you that these exercises are very simple. It's very, very important in any patient that comes in with a neck problem, with a low back problem, a shoulder problem. Use this technique and exercise as a combination with other techniques. So I will always look at the infrasternal angle first, try to fix that, and that will help guide my treatment. Start with these simple breathing exercises, then progress them to more complex. Measuring the infrasternal angle will take practice, but once you master it, it will be easy. And this is only one aspect of patient care, but one that you should definitely incorporate into your care. And since I've been using this technique, I've actually had better results, because this was a part of my care that I was missing. That I was saying, wait a second, patients are still having the low back pain. They're still having neck pain. I'm doing everything that I learned. Why are they not having carryover? And that's because we were not fixing their breathing mechanics. Okay, so this is something that I really want you to understand, that this is very important, and it will really help you guide your treatment. So let's just kind of recap what we learned today, because okay, so how do we measure the infrasternal angle? Well, they're going to be supine. You're going to mark the xiphoid process. You're going to measure angle ribs 8, 9, and 10, and then we're going to measure it. So okay, so we take a static measurement right here. Okay, just like that. And usually they'll be maybe 80, 85, 90, but the patients that are stuck at 60, 65 or stuck at 100, 110, those are the patients that we want to help. And remember, the key is you want to measure it. You want to measure it with their arms overhead. Okay, arms overhead. And taking that into consideration, make sure they don't arch their back too much. Okay. And then we're taking a deep inhalation. So watch this here. There you go. Nice. So he went from almost 85 degrees to over 100. That's normal. That's fantastic. And as he exhales, his infrasternal angle came down to about 70 degrees. That's perfect. That's what we want to see. We want to see the infrasternal angle move. So what's the normal range? What I like to see is, let's say they start off with 85, 90, then they can, on inhalation, they move to about 100, 105, 110, and on exhalation, they move down to about 70. That's a good normal expansion. If you get somebody that's only going from 80 to 85 to 75, that's a very narrow range. We don't like, that means they're not getting a full amount of air into their lungs. So we need to teach them to take a deep breath in and a deep breath out. Okay, so watch those ranges, and if it's a very narrow range, then you can cue them to do a little bit better in their breathing mechanics. Okay. So again, infrasternal angle is not static. It's a dynamic thing that we're measuring. Here's the umbrella that I was showing you. That shows you, okay? Now again, just to kind of reiterate, why do patients have a wide infrasternal angle? These are the patients that usually come in with an increase in thoracic kyphosis. That's because they have difficulty getting air into the anterior part right here. They have an increase in lumbar lordosis because they're usually obese. Wide infrasternal angle would mean that the false ribs are in inhalation position. Okay. Similarly, the infrapelvic angle remains wide, so pelvic floor issues. So observable phenomenon would be the guts expanding outwards during inhalation, big stomach, big kyphosis, creating this imbalance. So those are your usually obese patients. Okay, that will have a wide. So those patients, we want to recruit their external obliques and try to get them to do a forceful exhalation and trying to bring this rib angle down here. Okay, so good stuff. Again, the concept is not easy, but once you get this concept down, you're going to see amazing results, and patients are going to feel better. And it's very simple to do at home. Okay. So the key is you got the arms overhead. Okay, that's the key for treatment of wide infrasternal angle. Is wide, is reaching overhead, getting the external obliques to fire. Okay, so I hope that this is helping. You know, let's see here. Okay, so if you look at this, right here, overhead, just like that. Okay, so these are going to be some really, really good exercise for you to do, and very simple to incorporate. And in the Q&A session, if somebody has a specific question, now every patient is going to be different. There is no cookie cutter recipe, right? Some people might have a little bit of scoliosis. Some people might have some other issues. Everyone is going to be different, but at least you understand the concept, and getting them to breathe a little bit better, trying to fix their wide infrasternal angle or trying to fix their narrow. And this is not the only treatment that I would do if they have some other issues that we want to work on, but always, and this is what I've learned through doing this, start with fixing the infrasternal angle. Okay? Imagine this, if you don't fix the infrasternal angle first and you go do all your other treatments, you start doing, PAs, you do soft tissue, you do all this stuff. Imagine if all it took was them breathing, exhaling, and the soft tissue that you're working on doing all this stuff to loosen, it automatically loosens after just doing a few breathing techniques. Then you can move on to something else. You don't have to spend time trying to get a muscle to relax when all it took was 4 to 5 breaths. Does that make sense? So I hope that this is helping. I'm watching the chat, which is great. So I enjoyed the interaction that you have here. All right. So this one right here, this is a great exercise as well. Again, having the patient, usually because if they're overweight, they might have an imbalance. So make sure that you're there holding onto them or helping them with exercise, but them reaching overhead is really good. Okay. So those are my top 3 exercises for a wide. These are the ones that's a little bit more advanced, the reverse lunge here. Yeah, so there I said with ankylosis, with pelvic asymmetry, SI issues, lots of stuff. Patients suffering with pigeon stents. So some of this stuff you want to try. Again, everyone's going to be having a different, we can't go over every single diagnosis that's going to walk in the door. And some of it, if it's structural, or if you might not make a permanent change right away, but at least you can start teaching them about the breathing and the mechanics there. But it works really good on patients with scoliosis, so you can definitely do that on patients with scoliosis. Usually patients with scoliosis, they'll have the asymmetrical. So you'll have to work and see which side is narrow, which side is wide, and then try to correct it that way. Okay. This is one that's a little bit higher level, but I really like this one. Okay. Okay, so half kneeling and then with the weight here. So this is really good. If a patient is not able to put the hands above head, how to measure infrasternal angle? Well, if they can't put their hands overhead, you can have maybe an assistant or anything hold it up overhead. Okay, and see. All right. So again, narrow, usually lean women, and they usually lack serratus and pectoralis, and that will definitely cause them, and we want to recruit that as well. So, and the key is quadruped, and then we want to get a posterior rib expansion right here. Okay, so I just wanted to go over this. Again, you'll be able to watch this video and and go over the exercise, but I think it's It'll be one thing that you probably haven't heard of. This is a new concept for you, and you're thinking, wow, I've never even thought about this, but imagine incorporating this into your routine, and I think it will really be beneficial to your patients. Okay, so I have again, references: Zach Couples, Bill Hartman, and Postural Restoration. These are the main websites that you can read up more about. You can watch YouTube videos on this, but then I have a ton of, there's a lot of reading that goes into this, and there's a lot of information about the infrasternal angle, the breathing patterns, dysfunctional breathing, and if you're bored and you want to learn more, here's 24 references that you can look up on Google Scholar. And then if you're like, oh man, I need more, okay, here's another 15 for you to look at. Okay, so a lot of this took a lot of research to find. But if you look at some of this stuff, some of this is really good. The effect of muscle fatigue and low back pain in lumbar movement variability, the mechanism of inspiratory action on the rib cage, really good stuff. The role of the diaphragm in trunk rotation in humans, the action of the diaphragm on the rib cage, mechanics of respiratory muscle, postural and respiratory function of the pelvic floor muscles. I really highly recommend anybody that does pelvic floor therapy to really read this article, but also look into infrasternal angle. But there's a lot of good stuff. Recognizing, treating breathing pattern disorders, Atlas Anatomy, also knowing the anatomy. Okay. Does unequal leg length cause back pain? Analysis of posture and back pain in the first and third trimesters of pregnancy. So you have to be careful with pregnancy. We don't want to do forceful inhalation. So, and you don't want to push on the pregnant mother as well. So you have to be careful during pregnancy. But in early stages of pregnancy, yes, but late stages, second and third trimester, you have to be careful. Okay. All right. Perfect. So hopefully that helps. We can maybe do a Q&A. All right.
Yeah, it was fantastic, sir. Everyone is enjoying. So they have asked a lot of questions. Few questions you have already attended.
Yeah.
Before we take questions, I would like to inform them few things, sir.
Sure. Yeah.
Friends, regarding the certification, there is one certificate combining both level 1 and 2. So those who have attended both the levels will be eligible for receiving the certificate on this infrasternal angle, and we will issue the certificate by 8th of the August. So before that, you need not have to send me any screenshot or anything. If you won't receive the certificate by 8th, then definitely you can contact me on the mobile number we are sharing in the scroll. So you can share your 3 screenshots of different time frame, which already is mentioned regarding your chat, and the screenshot of the form filled by you. So that is what is necessary for the certification. If anyone is having any other issue regarding the previous webinars, then they can also contact me on the same number for the certification. Thank you so much for that. Sir, may I take the questions, sir?
Yeah, if you have some specific questions, again, try not to ask a specific question that you have a patient that does this. There's a lot of dynamics to it, but if you have more of a general question of narrow versus wide, because I saw in the chat there's very specific questions to a patient. Again, without me knowing the medical history of the patient, I can't just blankly say this is what I would do. But if you have questions about the narrow or the wide or implementing, that I can answer, but not a specific, like a patient question, because that would be difficult without knowing the whole background. So.
So Heta is having the question.
Sir, how will we come to know that one side is increased and opposite is reduced? How we will come to know? You mean by measuring, when you use the goniometer, you'll see, okay, so here's the xiphoid process, okay? What you can do is you can go cut it in half just like this and measure one side, and then measure the other side here. Okay, and you'll see sometimes, so right where the xiphoid process is, sometimes you can measure it, one side will be narrow, and then on the other side, it'll be wide like that. You'll be able to visually see it on asymmetrical. Anybody that has scoliosis, it's pretty obvious that you'll see the asymmetrical infrasternal angle on that. But the key is, if you want, you can draw a line right down where the xiphoid process is and measure it from here and here, and you'll see the asymmetry. It's very, I haven't found, usually you'd be really wide or they'll be narrow. Asymmetrically is, you won't see it as much, but I have seen it. So, okay.
Sir, many are asking about the references. The reference list was not readable. So
Okay.
they are asking that, can we share that?
Yeah, I'll give that to you, and then you can share that with them. A lot of good references, a lot of good articles on that for sure.
Yeah, along with certificate, we will share this also.
Yeah, there's about 50 references that they can read up on. So, and then the 3 websites, they're the Zach Couples, the Bill Hartman, and Postural Restoration. They have a lot of good information as well. But those references, those articles are really good if you really are into evidence-based treatment, which I think a lot of people should be, because there has to be a reason why we do this stuff. We just don't, and patients want to know, why are you doing it? And there's a lot of research behind it for sure.
So one question is from Ramin.
If the patient is having any other issue like OA, chronic pain, or lower back pain, should we directly treat it before making the ISL? No, I would start with the infrasternal angle first. As I mentioned in the webinar, chronic pain, how would you treat chronic pain if you don't fix the infrasternal angle? By fixing the infrasternal angle, guess what? The chronic pain might actually get better. So I've like I said, start with the infrasternal angle, whether they have neck pain, whether they have chronic pain, whether they have shoulder pain, and you'd be surprised as the results that you'll get with that. So that's a good question. But anybody that comes in with chronic pain, OA, stenosis, spondylolisthesis, any itis, start with the infrasternal angle, and that'll help you. Because remember how we talked about in the philosophy portion last week is breathing is so important. And if they're not breathing correctly, that can lead to a lot of chronic problems. So
Raina is having a question.
Is there a particular degree of increment in the ISA that is normal? What is a good range? Yeah, perfect. So like I said, let's say a patient is starting with 90 degrees. When they take an inhalation, I like to see about a 10-degree increase. So if they're going from 90 to 100, 105, a 10, 15-degree improvement, that's fantastic. Now, 90 degrees here, and then when they exhale, they're going down to 80, 75. That's a good range for them to go. We don't like to see a narrow range. So let's say they start at 90, they only go to 95, and they're only going to 85. They're not breathing real. So a good 10 to 15 degree expansion here and 10 to 15 degree expansion is, I think, a normal good breathing mechanics. So very good. But the key is make sure you know where they start. So let's say they start at 80 and they're going to 95. Well, that's 15. I don't want you to think that they have to be over 100, but you saw where they started. Okay, right? So and then they go from 80 and they're going down to 75. That's not, they're not exhaling as much, but if they go from 80 to 60 or 70, then that's a good expansion. So try to get about a 10 to 15 degree expansion from inhalation to exhalation. Okay. Can ISA affected by respiratory condition, restrictor, obstructor? Yeah. So your blue bloaters and pink puffers, COPD, emphysema, all those, definitely. Those are things that that can affect how their breathing mechanics are, and implementing these techniques will help. Now, if they have end-stage lung cancer, if they have all this stuff, this is not going to cure them, but it can make their life more comfortable for sure, trying to get them to breathe in and out, and doing a little bit better. So I would use that on emphysema, COPD, you name it. They're going to have a very difficult time breathing out, exhaling. So they can breathe in, but they can't breathe out. So those are, but anybody that's restricted, obstructed, I would use this technique for sure. Yeah. Just be careful trying to get them that forceful exhalation, because if they haven't really breathed out that much, you'll see a change in their blood pressure, you'll change in their O2 content, and they might get a little lightheaded because you're bringing air into something that hasn't been there for a long time. They're going to be like, oh, I'm getting a little dizzy or lightheaded. But as they breathe in and out, they're going to feel much better. So anytime that you increase the oxygen content and the degree, there's going to be a fluctuation, and patients are going to be like, oh, why am I dizzy? That's because, hey, this is the first time that you're taking a good breath of air. If patient's not able to do hands above head, then how to measure angle? Someone measure that. If they can't put this here, you can help them by putting that up there. When you can take it passively, and the key is see if they arch their back. If they arch their back, that's too much. You want to be right about here, and then take a deep breath in. So you can support it. That's fine. As a therapist, you can help them. We talked about this last time, obese patient having a large belly. You should be able to measure it. I mean, the belly is here, but the rib angle is right there. So by putting that on there, I mean, I've had many patients that are obese or overweight, and I'm still able to measure. I mean, you have to dig in there a little bit, but you'll be able to measure it for sure. And those are the people that are going to be wide. Okay, they're going to be stuck wide. You'll see that. So exercises are to be modified for geriatric population. If so, yeah, the thing with geriatric population is you have to be careful with osteoporosis. You have to be careful. You don't want them to do when you put your hands on them. Be careful, but anybody that you don't want to limit it. There's like geriatric. You just have to modify a little bit so that you don't cause any harm, right? So if they can't get into quadruped, if they can't, obviously, the reverse lunge and the half kneeling is going to be difficult for the geriatric population, but you don't want to limit it and say, hey, oh, he's 70 years old, he shouldn't be able to do it. Try it, and then if they have difficulty, but you don't want to put a label and say, oh, just because he's older, we don't want to do it. Just be careful, use common sense, right? And you'll be fine. I've had patients that are 80 years old, and I've done this, and they feel much better. So I don't want you to think that, oh, it's too late. 80 years of breathing mechanics, and then we can't change it. Of course, you can change it. You can always change it. So have a positive outlook, and they'll thank you for it. So again, this is more specific. If a patient suffering with a pigeon chest and stenosis is also present, this is very specific to that. What exercises should be used? Well, it goes back to the whole seminar of where's their infrasternal angle, right? I mean, you can have somebody with a pigeon chest that might be narrow, or they might have wide. It depends on how they've compensated. So measure the infrasternal angle, and once you get that, then you know exactly what exercises you should do. Don't treat the patient as the diagnosis of pigeon chest. You want to see how has the patient compensated. Have they compensated as a wide, or have they compensated as a narrow? Then that becomes your treatment. Remember, stenosis is just a diagnosis. We don't treat someone based on that. How have they compensated for their stenosis? How have they compensated for their pigeon chest? And then your treatment becomes easy. That's why I gave you those exercises. So very good. Some patient with ankylosis and some with pelvic symmetry. Of course. Yep. Right? Because you're not going to change the ankylosis, but because of the ankylosis, they're not breathing correctly. So how have they compensated for that? And then you'll be able to. Pelvic asymmetry. Why do they have the pelvic asymmetry? And like I mentioned in the seminar, that the pelvic asymmetry might be due to the infrasternal angle and the infrapubic angle being so the pelvic asymmetry. So imagine this. And so let's say somebody comes in with pelvic asymmetry. You measure, their hip is shifted one side, one is anteriorly rotated, one is posteriorly rotated, and you do a good manual technique, right? And then it's neutral. But then as soon as they stand up and they walk, guess what happens? Boom, again. Because you didn't fix the breathing mechanic of that. So then it's a temporary thing. So what I would do is I try to fix the breathing, the infrasternal angle, and then measure that, and you'll have a better carryover because you fix the breathing component, and then you'll have a better carryover with the pelvic asymmetry. That's what I found is before I fix anything manual, I start with the breathing, and I've had better success that way. So good question. What are the instructions you provide to the patients for breathing? Anything specific? I'm not I'm not understanding the question. What do you mean by anything specific?
Sir, I think he wants to ask that when you are asking patient to do breathing along with the arm movements or a body movement, do you give any specific instruction to the patient regarding breathing?
Okay, yeah, I understand. So on a wide infrasternal angle, the key with this is a good question. Now I'm understanding it. With a wide infrasternal angle, we want the exhalation to be forceful. So it's going to be. So that's the verbal cue that I want to give with a wide, because we want the external obliques to fire. So the only real way to get the external obliques to fire, it has to be a forceful exhalation. So I tell it, I really. Okay, with a narrow, it's not a forceful exhalation. We want the serratus and the pec. So I tell them, hey, I have my glasses, and if I have a glass here, I'm just going. That's the breathing for a narrow. So it's just like you're fogging up glasses. It's going to be. You see that? So that's what I would do for a narrow, and that will be better. I hope that answers your question. That would be very specific. So remember, with a wide, it's a forceful exhalation. With a narrow, it's fogging up glasses. And that's the very important. Good question.
Yes.
So again, this is a little bit more specific, affects the, I just mentioned that this would be a whole different lecture, right? How it affects that, but it is something that it does affect the pelvic floor and the infrapubic angle. That's a totally different thing. But what I would like you to do is start by looking at the wide and infrasternal angle, and you'll be surprised how it does affect the pelvic floor, and they'll be better off. So treatment for pelvic floor is very specific, but before you start that treatment, look at the wide and the narrow infrasternal, and I guarantee you a lot of times the pelvic floor will relax after you do the techniques, and you won't have to work as hard with the pelvic floor. So we've had some good results with that. In the mixed ISA patient having, how will the expiration pattern be? Good question. So usually the asymmetry is due to the wide overcompensating, so it's a forceful exhalation. Okay, so the breathing pattern is take a deep breath, and it's a forceful exhalation. Okay. If the thoracolumbar junction is stiff, what would be the findings and respective management? So there's a lot of techniques. So somebody that comes in with thoracolumbar, there's a lot of good exercises that I give. I did have a session on open book, thoracic rotations. I mean, there's a lot of stuff but before I do that, I'd fix the ISA, and then I do, rotations here, open book this way. There's a lot of exercises for the thoracolumbar junction. Today, I mean, I focused on just the ISA exercises, but maybe in the future we can just do very specific thoracic exercises for thoracolumbar stiffness, because the two main areas, and this is a good, you bring this up, is, okay, imagine what, and this is more of teachings of Great Cook. He says that the entire body is usually mobile or stable. Okay, so this is again teachings of Great Cook. So the ankle should be mobile. We know that the ankle should be mobile. Okay, the knee should be stiff. The hip should be mobile. Okay, very mobile. The back, we know it should be stable, but the thoracic spine should be mobile. And imagine this, if you have a stiff thoracic spine, your body is going to compensate above and below, right? So if I don't have movement here, I'm going to get too much movement in my lumbar spine, and I'm going to get too much movement in the neck. Okay? So what we want to fix, and imagine, say we have real stiffness in the hip, what we're going to try to do is we're going to compensate at the lumbar spine and move too much, and that's where our herniated disc can happen. Imagine if we have stiffness in our hip, then we'll try to get too much movement in our knee, and those are meniscus and ACL injuries. So you can see how the body starts to compensate above and below. And so we want to fix the thoracic spine, and we want to fix the hip. So let's say I fix the ISA, My two joints that I go to next is the thoracic spine and the hip. Okay, so if somebody comes in for low back pain, I don't even touch the low back until I fix the ISA, I fix thoracic mobility and hip mobility, and you'll get better results that way. Okay, so treating that way. And then patients are like, hey, I'm here for my low back. How come you don't even do that? But once you explain that, hey, this is the reason you have pain in your low back is because you've compensated all this time. So we want to fix what's causing your pain. So a lot of times we only focus on the diagnosis. Somebody comes in with knee pain, we're focused on that. But if they have stiffness in their hip, if they have stiffness in their ankle, and we never address that, they're going to continue to have knee pain, right? If they have low back pain, we just keep pushing, doing PAs and doing soft tissue at the low back, but we don't fix the hip or we don't fix the thoracic spine, they will continue to have low back pain. So this goes back to, if we don't fix the ISA and we don't fix the breathing mechanics, they'll always have neck pain. They'll always have low back pain. So we're finding the source of the problem. So I'm just trying to educate you into looking at further things. And like I said, I just came up this recently, and I want to share this because I think it's something that I wish I knew 10 years ago, 15 years ago. I imagine all the patients that I could have helped. But hey, it's never too late to learn something new. So it's good. So how long should we treat the patient to bring the ISA intact? Good question. In some patients, I see the results right away. Someone that, and then you teach them the breathing mechanics for home. But then on some patients that have more of a chronic issue, it may take a few sessions too. But the key is, how much do they do at home? Okay. If they're very diligent with their exercises, you will see really good results. If they're not diligent and they always say, oh, it's not helping, you ask them, how many times did you do it at home? They'll say, oh, once. It's not going to work. I mean, just like with any home exercise, if they don't do their exercise at home, it's not going to, you're not going to see the results. Okay, so, but those that follow it, they're actually going to be really good. Effective infrasternal angle in neurological conditions. You mean what? Well, there's a ton of neurological conditions. You mean stroke, cerebral palsy, MS? I mean, what? Again, that's a little bit too specific. I don't. Do you, Dr. Patel, what you want to share? What do you think?
Sir?
Srikant had a good question. Effective infrasternal in neurological conditions. So it's too broad. I'm trying to answer it the best way, but I don't know if I can answer it just because there's so many neurological conditions, right? But it goes back to, go ahead.
Yeah, you can share any reference details also.
I do. In the reference list, they actually have two good articles on neurological patients with CVAs and kids as well. So, and kids with scoliosis and cerebral palsy or with MS. So there's a reference with that, but they treat it the same. Again, the neurological condition is just the diagnosis, right? Cerebral palsy is just a diagnosis. CVA is just a diagnosis. What is their compensatory pattern? What is how have they substituted? And it goes back to how they present in the clinic. Because think about this. If you have a patient that comes in with a diagnosis of stenosis, every patient that walks in the door is not the same. Patient that has a diagnosis of cerebral palsy, no two kids are the same, right? They might compensate. One might compensate with a wide, one may compensate with a narrow. So I can't make a general statement that, hey, everyone that has cerebral palsy, you should do this. No way. How do they come into the clinic? How do they present? And what are their, that's the way. So that's the kind of mindset I want you guys to think, is that don't get stuck on the diagnosis. I want you to see what is the compensatory pattern and how does the patient present in the clinic, because every patient will present differently, even with the same diagnosis. Think about low back pain. How many patients have walked in the clinic with low back pain? Are they all the same? No way. You're going to come in a patient that has low back pain. Someone's going to be wide, someone's going to be narrow, short, tall, fat, skinny, you name it. There's a wide reference, but the diagnosis is the same. So is it pursed lip breathing can also help in this condition? Yes. Again, the pursed lip breathing is, we want to exhale out, and that would help a wide, but then for the narrow, so it's a different kind of breathing in and out. So what are the effects of wide narrow on shoulder and hip mechanics? Well, I mean, that was the whole presentation of how you can really, everyone's going to be a little bit different. So, but it will definitely affect the shoulder, definitely affect the hip for sure. I found that, and that's a good question, is I found that once I actually treated the wide infrasternal angle or the narrow, actually their shoulder mobility increased so much. A perfect example is glenohumeral internal rotation. Somebody that has glenohumeral internal rotation limitations, after teaching them breathing, guess what? Their internal rotation goes down without even touching the shoulder, because what you did was they were shifted one way. Now you've basically brought them to neutral and their internal rotation just goes down. Usually what we do is if it's a capsular pattern, we'll push, and you didn't need to do that. And all you had to teach was basically a way for them to breathe correctly. And you'll find that their glenohumeral internal rotation is much better without even touching it. And their hip mechanics, their hip internal rotation, external rotation will improve as well. So good question, Abhishek. But start with the infrasternal angle, and I think that will help you. Again, it's not, I don't want you to think that, hey, once I cure the infrasternal angle, everything falls into place. But I want you to start there and then do your other treatments. I don't want you to do it last, because then it won't be. For evaluation, we had forward bending, squat, shoulder movements, etc. We use the same movement as treatment approach? What do you mean?
Sir, I think she wants to ask that we are using movement while diagnosing the things. So can we use the same movements for the treatment as well?
I'm not sure I understand completely, because for evaluation, yeah, because we remember how we had them bend forward, squat, and all that whole thing. But the treatment would be the exercise that I showed you. So I'm not, I don't know, because there's no forward bending. That's not one of the treatments. That's just in the assessment, right? So, but the squat was definitely one of the, but the shoulder movements, well, for a wide, we want them overhead, and for the narrow, we want them here. So I don't know, maybe I didn't explain it right, but I'm not really understanding the complete question here. Sorry, but hopefully does that make sense? I don't know.
Yes, sir. Dipti, if you are listening to the answer, if you are still having a question, you can write the question again in the chat.
Yeah. Oh, good question, Asma. So 3 to 5 times, 2 to 3 times a day. Good question. Okay. So the breathing. So let's say they're overhead. You're doing wide. You ask them to exhale 3 times. Do 3 repetitions. 3 to 5, and then have them do it at least 3 times a day. Okay. Good question. Yeah, so sir, with the patient not able to do kneeling, so I would do the other exercises. That's why I gave you some variations. Those are just the ones that are kneeling. Those are higher. They're more advanced. So if they can't kneel, do the other ones. Yeah, the supine and the prone. Apical breathers may present with narrow. Do we still follow the activation of the serratus and pectorals? Yes. So apical breathers, usually a wide infrasternal angle, they're going to breathe. Okay. So what we want to try to do is we want to get air into the apical portion right here. Okay. So if they still present, so the key is, how do they present? Because they might have substituted more, right? So let's say you had a wide and then they started substituting, they became narrow, or someone that was narrow, they became wide. So it depends on how they compensated. So treat the infrasternal angle and how it presents, because that will teach you how the patient has compensated. So you'll be surprised that some people, they started wide and then they compensated to narrow, but treat what you see in the clinic. Okay, how have they compensated, and treat that. Okay, so So 3 to 5 times, 3 times a day. Do we have different protocols for pediatric patients, geriatric patients? Well, no, I don't think it would be a different at all. Pediatric patients is going to be difficult for them to understand, but if you're with patients, there's still, I would do the same exercises with the pediatric patients. And the geriatric patients, the same thing. You might want to modify. Geriatric patients may not be able to half kneel. They may not be able to do the reverse lunge. Do the other ones that are supine and prone, and then quadruped. Those are easy. Yeah, do the easier ones. So we're getting the same questions.
The second part is actually different.
Yeah, so the frequency is 3 times, 3 to 5 times, 3 times a day. So we got that. Many patients do the breathing exercise during the session, and the whole day they breathe just the way they breathe normally. Many patients do the breathing exercises during the session, and the whole day they breathe just the way they breathe normally. Yeah, I mean, what happens is you're not going to fix their breathing mechanics overnight, but what will happen is once the body starts to recognize the breathing pattern consistently throughout the time, they'll be able to, you'll be surprised how the body will become more efficient. Think about this. If I breathe incorrectly for 20 years, well, the body just keeps doing that. But then when I teach it to breathe correctly, the brain will say, okay, this is how I'm supposed to breathe, and it'll take over. But for chronic patients, it might take a while. But it does help. Again, as you know, with patient success, it's how much effort the patient wants to put into their own treatment. So if they want to get better and they follow our protocols, they will improve. If they rely on us and they only do it once or twice, you're not going to see the results. So really, you need to educate them, say, hey, try to do this as much as possible, and then you'll be better off. So. All right. I hope that was good. I mean, again, there's tons of questions, but I think the whole point, and it was a very good, hopefully a good session that we all learned from this. Last week we learned about postural restoration, why patients come in with certain patterns, why patients come in with certain presentations of neck pain, low back pain is because of the asymmetry we have. We use the infrasternal angle to see how they've compensated throughout the years, right? Once we find out the wide versus the narrow, then we use those exercises to normalize their breathing. And once I've done that, then I will go on to my other treatments, such as manual therapy, exercises here. So again, the key with this was introduce you to PRI, introduce you to infrasternal angle, which we did, and then introduce you to 3 to 4 simple exercises that you can incorporate in conjunction with your other treatments. So I think we accomplished our goals of the session. And again, it's very, there's always going to be questions because a patient may benefit, may not, but I would say that a vast majority of your patients will benefit from looking. Think about this. How many people that took this course never knew about the infrasternal angle, right? If you,
Yes.
Right? So, and then now this is another tool for you to help a patient, and you'll be surprised. Imagine if you can just help a small percentage get better, then you're better off because you never knew that the infrasternal angle was a key. But I guarantee you, since I've started incorporating the infrasternal angle treatments, my success rates for shoulders, hips, back have been much better and more long-term success versus short-term. So. So Nigel said in the wide infrasternal exercise, why we have to focus on the external oblique instead of the diaphragm. Well, the external obliques are going to help forceful exhalation, and then in essence, it's going to affect the diaphragm, right? So I can't say, hey, diaphragm activate, but if I use my external obliques, if I use that, then that will help inhale and exhalation, and the diaphragm will dome much better. So as an exhalation, the diaphragm will actually dome up. On inhalation, the diaphragm will dome down, and it'll help affect it. So the breathing mechanics is how we affect the diaphragm, and that's so good question there. Can we fix gas reflex or acidity with this exercise? I mean, there it doesn't hurt it to do it, but remember, like we talked about in the first session, if you have something, I have my esophagus that's being compressed with the diaphragm like this, and if I just take antacids, if I change my diet, but if I don't fix what's holding on to this, then you're only solving half the problem. So yes, I would definitely incorporate this into someone that has acid reflux. Think about who patients are usually have acid reflux and acidity. It's usually the big, heavy set, right? I mean, because they're stuck in a wide infrasternal angle, which is compressing the esophagus, and no amount of medicine, if they don't fix the breathing mechanics or if they don't fix their diet, they're always going to have acid and gas reflux. So we want to fix the cause. Well, usually they'll go to the doctor and they'll get the medicine to bring the inflammation down, but the long-term fix is diet, exercise, and breathing. All right, so what effects of measuring ISN breathing out for scoliotic patients? So again, that's a little bit more specific, but it just depends on how the scoliotic patient will present. Some will present asymmetrically. Okay, so we treat the asymmetry. Some will present with a wide, some will present with a narrow. So it just depends on how the patient comes into the clinic. But with scoliotic, most of the times you'll see asymmetry. Okay, so if I see on the right side, if I see it's a wide, then I treat the wide on the right, and on this side, if it's narrow, I treat the narrow. The exercise I showed you for the asymmetry. But with most scoliotic patients, you'll see asymmetry. Can you explain some serious complications of asymmetrical infrasternal angle like posture deformity? I don't know what do you mean by serious complications?
No, sir, I think he wants to ask that, Anisha wants to ask that if there is asymmetrical infrasternal angle, it can create any serious problem to an individual, like postural deformity or long.
Well, what you'll see is usually scoliosis, right? So that's a serious complication, postural deformity for sure. So someone that has asymmetry, we have a little bit of a lot of us present with a mild case of scoliosis, but some serious complications, it could be severe scoliosis. And in one of the references, they actually talk about scoliosis in detail, and that's in the reference there. So if you want to really read about that, that'd be good. Yeah, I know. With pediatric patients, it's a little difficult. I don't see too many pediatric patients, so I see more orthopedic patients, so it'd be difficult for me to comment on that because that's really not the patient population that I treat. So I apologize for that, but unfortunately, that's not my expertise. But I have had patients that are pediatric that have scoliosis that I have used the treatment for infrasternal angle and good results with that. Okay, so pediatric meaning 10, 12, 14, someone that is 5 or 6 years old, it's going to be very difficult for them to treat, right? So that do the best you can. Exercise for ISA can be done in spine surgery? Sure. Same. If yes, after how much time? So usually, because they're still recovering from the spinal surgery, I wouldn't start this until about 6 to 8 weeks after their surgery. Okay, because you don't want to increase the intra-abdominal pressure too much if they're doing it incorrectly. Okay, so be careful with them. So 6 to 8 weeks after any surgery, I would wait spinal surgery. But good question. That'd be but I would definitely, because think about this: if they had spinal surgery, they've been cut open and they're really having issues. Their breathing mechanics are going to be really affected. So this is something that I would definitely, and here's the thing. It would be a disservice if you did not do this exercise with spine surgery because they just had this complicated surgery. And if you don't fix the breathing mechanics, they say they're still going to have their chronic pain. They'll be like, why did I have the surgery? Right? So that goes back to, I think a couple of years ago, I had talked about total knee patients. And then remember the popliteus muscle that we talked about, and working on that. That's something that has really been beneficial as well. But with spinal surgery, working on the ISA would be beneficial as well, because it's something that I've incorporated.
So it's almost 1 hour and 30 minutes.
Okay,
shall I
yeah.
Question, sir? One more.
No,
question?
that's good. I think we can always keep answering the question, but I think that was good because I think they're more specific questions. The take-home philosophy is there. I think everybody understands that, and there's always any research. More research is always needed, right? Any kind of thing, we always want to do more and more. But I hope that everybody enjoyed it to the point where this is another tool for them to use. And if it was informative, we can maybe do more. I think the next one we can do the thoracic spine. I did a session live about, I think, 10 years ago. You remember that? I mean, you and I have been working together for a long time, but I have some different thoracic exercises. That's like my main treatment. I love the thoracic spine because that ties in with the diaphragm. And then so the hip and the thoracic spine are my two favorite areas to treat, because the neck and the low back is where the patients have symptoms. But if you treat the thoracic and the hip, above and below, they do really well. So
yes.
All right.
So thank you so much for your valuable time. It was
you're welcome.
A very valued information you have shared, and you made it in so simplified manner so everyone can understand it. The way you prepared the video, you took so much pain for us. That is phenomenal, sir. Thank you so much for everything. We really appreciate that. And it will be a great help to all the physio communities who are right now watching live, as well as to those who will watch afterwards, because your video goes viral once it is uploaded on the YouTube, as the history tells about the previous video too. So thank you so much, sir, for everything.
You're welcome. You're welcome. Good luck, everybody, with your careers, and I really appreciate the opportunity to educate. So hopefully we can do more sessions later on in the year. I start teaching full time in a couple of weeks, so I'm going to be busy, but I'll organize something with Dr. Bensali in the near future. All right.
Thank you.
Good luck, everybody. All right. Take it easy.
Thank you, viewers. Thanks for being with us. I really appreciate that. And if you are having any query regarding the certification, you can contact me on the mobile details I am sharing with you. There might be some issues with a few people, but as you all know, there are so many participants, and 3-4 participants might get some issues with the coping up with the certification, but we will make it a point. If you have attended, then we will definitely provide you the certificate. That's our responsibility. Thank you so much for joining us, and hope you will join us again next week also. We are coming up with a very big event with Oro University. It's a certification program for 7 days certification program. We are coming up with the neuro rehab 4-day session, which is starting from 6th, 7th, 8th, and 9th. It will be a neuro rehabilitation, and from Finland we will be having a faculty. So we will be having a wonderful sessions ahead, full packed with a lot of information and new informations to you. I wish you all will come and join those. We will share the necessary informations in the WhatsApp group as well as in the private also. So please join us once again. Thank you very much, everyone, and wish you a wonderful Sunday. Thank you so much.
Good evening, friends. Today we have a special guest with us, Dr. Denny Patel. Dr. Denny Patel graduated from Loma Linda University with a Master in Physical Therapy. He has also passed the Certified Strength and Conditioning Specialist examination. After practicing for 10 years, he went back to school and finished a doctorate in physical therapy. He has been practicing physiotherapy for over 21 years and has been teaching for over 16 years. He is a certified clinical instructor by the American Physiotherapy Association and took students and interns on regular basis. Dr. Denny Patel currently teaches human anatomy and medical terminology at Costline, human anatomy and motor control at Cal State University, human anatomy at Santa Ana College and pathology at St. University. Thank you.